Welcome to our 93rd webinar. For those of you who don't know me, my name is Shoaib, and today we will be covering antibiotics and an introduction to infectious diseases. But what I really want to focus on today, the basics of antibiotics, because students often find that tricky. You know, what antibiotic do you use to treat which organism or which disease? So I thought it'd be quite a useful topic to cover. Probably split this into 2 or 3 parts. So today, as I said, I'll go over the basics and I'll cover respiratory and urinary tract infections. And then the next webinar, Azim will cover abdominal and cerebral infections. And we may do a part 3 on sort of the more niche tropical rare diseases like, TB type infections. So hopefully this won't be more than sort of 50, 60 minutes. And the slides are available on app.bitemedicine.com. So please do download those so you can follow along. For those of you who don't know, we have a question bank. So please do check that out along with our webinars. And that takes you through a case-based approach, taking you right through the first steps and investigations of a case through to the management. So I think it's quite a useful question bank and associated textbook. So please do check that out. There's a bunch of free material on there as well for you guys. Oh yeah, and there's a discount of Shoaib 2021. That discount code will get you 20 or 30% off. So again, if you haven't yet signed up, then you can use that discount code and that should get you 20 to 30% off. All right, without further ado, let's get started. The basics of antibiotics. Before we start, we need to understand the structure of a bacteria. So in particular, what I want to focus on is the bacterial cell wall. And what do we mean by gram-negative and gram-positive? Well, the bacterial cell wall comes in 2 versions. We've either got this one on the left or this one on the right. For the one on the left, you've got an outer cell membrane and you haven't got much of a thick peptidoglycan cell wall like you do here on the right. So on the right, you have a nice thick peptidoglycan cell wall. On the left, you do not have that. When I get my gram stain, which is a purple stain, and I wash both of these with the gram stain, what's going to happen with the gram positive compared to the gram negative? So that's a question for you guys. You've got one with a thick cell wall and one with a cell membrane. When I wash these with gram stain, what's going to happen to the gram positive? Will it retain the gram stain or will it all kind of just wash out after? Yeah, good. So the gram positive bacteria, the ones with the thick cell wall, they retain the gram stain. The stain is purple. So of course, these bacteria will appear purple under the microscope. The gram negative does not retain the gram stain and it is not purple. So this is a slide. We have a purple bacteria and that's gram positive, and we have a pink bacteria and that's gram negative. So just to go over that, the thick cell wall holds onto the gram stain, which is purple, okay, and therefore these bacteria with the thick cell wall appear purple under the microscope, and that's referred to as gram positive. The bacteria which only have that outer cell membrane, they do not retain the purple stain, and they are called gram negative, and they appear pink under microscope. So which bacteria is this most likely? Which bacteria is the purple one? It's a gram positive coccus, and it's clumped together in a grape-like structure. So yeah, that's Staphylococcus aureus, very good. And the pink one is a gram-negative rod. So do we have any example of gram-negative rods? E. coli, very good. So that's probably one of the more common ones. There are many examples of gram-negative rods, but yeah, E. coli is a good example. Okay, first question. If we pop over to Menti, So if we go over to menti.com and we pop in the code 58923383, you can answer the question, which of the following does erythromycin bind? Dihydrofolate reductase, the 30S ribosome subunit, 50S subunit, DNA gyrase, or RNA polymerase? Bit of a tricky question to get started with, to be honest, but I think it's something that you guys do need to know, unfortunately. Give you guys another 10 seconds or so to answer. Okay. Very good. It's the 50S ribosome subunit. I'm surprised so many of you got that right. So really well done. It is indeed the 50S ribosome subunit. So dihydrofolate reductase, that trimethoprim binds to that, and that blocks folate synthesis. Tetracyclines and aminoglycosides bind to the 30S ribosome subunit. Fluoroquinolones bind to DNA gyrase, and rifampicin binds to RNA polymerase. Macrolides, like erythromycin, bind to the 50S ribosomal subunit within the bacteria. If this all just sounds like a bunch of, jargon to you, don't worry, we'll go over it all in the next few slides. So just briefly, we can split up the mechanism of action of antibiotics into 3 subtypes. Those which affect the cell wall of the bacteria and block cell wall synthesis, those which block protein synthesis, and those which block nucleic acid synthesis, i.e. basically DNA synthesis. And then within these 3 subcategories, you've got the various types of antibiotics. So starting with probably the ones that we use most commonly are the beta-lactams, and most commonly penicillins. Other types of beta-lactams are cephalosporins and carbapenems. I've never used monobactam before, so just don't worry about that one. But penicillins, cephalosporins, and carbapenems are all examples of beta-lactams. What is a beta-lactam? It's a particular sort of ring-like compound structure which interferes with bacterial cell wall synthesis. Okay, vancomycin also blocks cell wall synthesis, and polymyxins and things. I wouldn't worry too much about that. In terms of protein synthesis, so we can either block the 30S or the 50S ribosomal subunit. 50S subunit is blocked by macrolides like erythromycin, clindamycin, linezolid, and various other antibiotics. The 30S subunit is blocked by tetracyclines and aminoglycosides. And then finally, you've got those antibiotics which block nucleic acid synthesis. So those which block folate synthesis, remember folic acid or folate, they're the same thing, really important for DNA synthesis, trimethoprim and sulfonamides. Okay, DNA gyrase, which is an enzyme used in DNA formation, is blocked by fluoroquinolones, and RNA polymerase is blocked by rifampicin, also known as rifampin. So this is a brief overview of the mechanisms of action, and you do unfortunately need to know the mechanisms of the common antibiotics like penicillins, cephalosporins, vancomycin, etc. Looking at this in a bit more detail, so if we start off with those which block cell wall synthesis, starting with the penicillins, we have things like amoxicillin, penicillin V, and penicillin G. So penicillin V is short for phenoxymethylpenicillin, and penicillin G is short for benzyl penicillin. When we think about antibiotics, we need to think about what organisms can these antibiotics actually work against. Penicillins are active against both gram-positive and gram-negative bacteria. Okay. Cephalosporins are also a type of beta-lactam, and they can be divided into, there's actually 5 generations. I've just listed 3 of the generations here. So first generation, second generation, and third generation, and examples are listed underneath. Does anyone know what the difference between the successive generations are for cephalosporins? Because you may have heard people say, let's use a third generation cephalosporin, but not actually know what it means. So what it is that when cephalosporins were initially made, you had the first generation, and they were good against gram-positive bacteria, but they weren't very good against gram-negative bacteria. So with each successive generation, as someone's correctly said in the chat, you get better gram-negative cover. So ceftriaxone covers both gram-positive and gram-negative bacteria. Cefalexin primarily covers gram-positive bacteria. So with each successive generation, you get better gram-negative cover. Carbapenems such as meropenem and ertapenem, these are broad spectrum. They cover a large range of bacteria, gram-positive and gram-negative. Glycopeptides like vancomycin predominantly only really cover gram-positives, and vancomycin is in particular used if the patient has an MRSA infection. So if a patient has MRSA, typically we treat that with vancomycin. Moving on to the next class, we have protein synthesis, those antibiotics which block protein synthesis, so macrolides, tetracyclines, aminoglycosides, and liconosamides. Macrolides, they end in mycin, so azithromycin, erythromycin, clarithromycin, and they predominantly cover gram-positive bacteria. They don't have much activity against gram-negatives. Tetracyclines like doxycycline, tetracycline, and oxytetracycline can cover both gram-positive and gram-negative, and aminoglycosides predominantly cover gram-negative bacteria, and they end in mycin, or in sin rather, gentamicin, amikacin, and neomycin. And then finally, we have clindamycin down here, which is predominantly gram-positive cover. And then the last class, those which block nucleic acid synthesis, so sulfonamides like sulfamethoxazole cover both gram-positive and gram-negative bacteria, and fluoroquinolones end in floxacin, like ciprofloxacin, levofloxacin. Again, these cover both gram-positive and gram-negative bacteria. There's a lot of information to take in, and I think what's more useful, and I'll have it in a slide coming up, is rather than thinking about what type of organism does fluoroquinolone protect against, rather think about what infections is fluoroquinolone used in. So if we go through some of these, when do we typically use macrolides, for example, in what types of infections? Or in any particular infection you can think of, when do we use macrolides? Good, pneumonia. Okay, so that's a good start. And remember, macrolides cover gram-positive bacteria. Often pneumonias are caused by gram-positive organisms. That's why macrolides are useful. Let's take aminoglycosides, for example. So if I say gentamicin, when do we typically use gentamicin? So think, it's a gram-negative, it's an antibiotic which covers gram-negative organisms. So what type of infection would we use it in? Got an interesting range of answers. So yeah, typically urinary tract infections, including pyelonephritis. In severe urinary tract infection and pyelonephritis, you can use gentamicin, because urinary tract infections are very commonly caused by gram-negative bacteria. Someone's also said neonatal sepsis. That is correct. You can use gentamicin in neonatal sepsis. This is essentially the table I've just listed, but in a picture version. I would not bother learning this because It's really complicated. Sorry, there's a little text box over the picture, but I would not bother learning this because it's just too complicated. I would stick to the table. From this, what you can take away is what antibiotics are broad spectrum and what antibiotics are narrow spectrum. So when we say broad spectrum, we're talking about an antibiotic which covers a large range of bacteria. So if we look at meropenem, for example, it covers anaerobes, it covers gram-negatives, and it covers gram-positives. It stretches all the way across the diagram. That is a broad spectrum antibiotic. If we look at penicillin G, for example, that has very limited cover of predominantly streptococci. So that's a narrow spectrum antibiotic. That's kind of the key take home from this diagram. So you can see which antibiotics are broad spectrum and which are narrow spectrum. I wouldn't go through this and learn the sort of nitty gritty details because you'll, you know, it's just very complex. Okay, fine. So we have an infectious disease in front of us. Patients presented to the emergency department, they have a particular infectious disease. You need to think about which antibiotic am I going to choose? Of course, we have guidelines, but to try and understand those guidelines, we can use these 4 principles. So firstly, the antibiotic you use needs to be able to access the infection. Okay, some antibiotics, for example, are really good at entering the urine and targeting urinary tract infections, whereas some antibiotics aren't very good at entering the urine. Some antibiotics cross the blood-brain barrier and can fight off things like meningitis, but some antibiotics can't cross the blood-brain barrier and are therefore, although they may be useful in fighting off that particular organism, if you can't access the infection, it's useless. So the first step, think about where the infection is. Secondly, what organism is the cause? Because as we've seen from that previous table and the previous picture, some antibiotics cover some organisms and not others. Thirdly, you need to think about the severity. You know, are you going to use oral or IV antibiotics? Are you going to use something which is broad spectrum or narrow spectrum? And finally, you need to think about the contraindications. Does the patient have penicillin allergy? In which case you can't, of course, give them things like amoxicillin, coamoxiclav, etc. So these are 4 points to bear in mind when picking an antibiotic. And I would say this table is probably the most high yield table in the webinar. And it's kind of based on a combination of guidelines and my experience. The problem is antibiotics vary so much across the country because they're based on local guidelines. And it's unlikely in your exam they'll ask you, you know, for really specific niche antibiotics to treat particular infections. So what I've tried to do here is just create a sort of general approach, starting off with cellulitis, most commonly caused by Staph aureus and also strep pyogenes. And it's most commonly treated with flucloxacillin, okay? Again, these antibiotics will vary from trust to trust and depending on what part of the country you're in, but in general, all of the antibiotics I've written here are acceptable. Tonsillitis, so remember, firstly, think about where is the infection. So tonsillitis, it's in the throat. Which organism are we dealing with? Strep pyogenes, most commonly, also known as group A strep. Then think about severity and contraindications. And once you've thought of all of that, the most commonly used antibiotic to treat tonsillitis is phenoxymethylpenicillin. Pneumonia, we're going to go into in a lot more detail later on, but again, this is a little summary of the antibiotics that we use. Pneumonia is typically divided into community-acquired, hospital-acquired, and aspiration pneumonia. But again, we will go on to that. Intra-abdominal infections, most commonly caused by gram-negative bacteria like E. coli or anaerobic bacteria. These are the bacteria that live in your gut, and we'd use things like coamoxiclav or a cephalosporin plus metronidazole. So metronidazole is really good at covering anaerobic bacteria, which is why we use it here. When I say intra-abdominal infections, I'm talking about things like cholecystitis, appendicitis, intra-abdominal abscesses and collections. And yeah, as I said, typically coamoxiclav or cephalosporin plus metronidazole, because we need to cover both gram-negative bacteria and anaerobic bacteria. Urinary tract, we're going to go into in a lot more detail later, but the most common organism by far is E. coli. And if we're dealing with a UTI, nitrofurantoin or trimethoprim are the common agents that we use. And meningitis caused by strep pneumonia, Neisseria meningitidis, or listeria, these are all adult causative organisms. In younger children, you can also get E. coli or group B strep causing meningitis. And we typically use a third generation cephalosporin like ceftriaxone. Okay, that's everything I wanted to cover in terms of antibiotics. So that's a little crash course in antibiotics. Feel free to review the slides in your own time. But what we're going to do now is we're going to move on to a case. So read this carefully. We have a 60-year-old lady who presents to A&E with shortness of breath and a productive cough. On examination, she's warm to touch and has right-sided coarse crackles or coarse crepitations. Those are her observations there. So her heart rate is 107, blood pressure is 99/56, rest rate is 28, saturation is 93%, temperature is 38.6. Okay, taking those observations, because I'm going to ask you what the curb score is on the next slide. So have a good look at those observations, and then we'll move on to the question. So heart rate 107, BP 99/56, rest rate 28, saturation is 93%. The patient has a urea of 8. What is her curb score? So if you didn't catch it, her heart rate was 107, rest rate was 28, and blood pressure 99/56. Her urea is 8. What is her curb score? So this is something, again, that you need to be able to calculate for the purposes of your exam, and it's quite important clinically as well. Okay, so we've got a curb of 2 as the majority answer. For those of you who answered 2, why has she got a curb score of 2? Urea and blood pressure, okay, good. So there was a little trick in this question, which most of you didn't fall for, so that's very good. Her heart rate is 107. Heart rate's not relevant for the curb score. The blood pressure and the rest rate are. So her rest rate is less than 30, so she doesn't score for that. Her diastolic blood pressure is less than 60, so she scores 1 point for that. Her diastolic is less than 60, so that's 1 for that, and 1 for her urea, so a total of 2 points. We'll go on to the curb score again later. But it's a way of grading the severity of the pneumonia. And in this case, she scores for her blood pressure and her urea. So what is pneumonia? It's a lower respiratory tract infection where your lower airways fill with inflammatory exudate. Essentially, you have the inflammatory process occurring in your lower airways. Then you have inflammatory exudate collecting in the alveoli. And that's actually why when you listen to the chest, you hear crackles. Okay, crackles indicate the presence of fluid in the alveolar airways. And also, this is the reason why patients have consolidation on their chest x-ray. Because when you have fluid, which is inflammatory cells, debris, inflammatory exudate filling the airways, you get this white patchy opacity on the chest x-ray, and that's known as consolidation. It's, it's fairly common, 220,000 diagnoses per year in the UK in 2019. Risk factors include extremes of age. Of course, immunosuppression is a risk factor for any infection. IVDU, so intravenous drug abusers, and patients who have any underlying lung pathology like COPD or cystic fibrosis, for example, are more susceptible to pneumonia. Okay, next question. The patient tells us she's an alcoholic and the sputum is a deep red color. What is the likely organism? Okay, very good. 90 or 80% of you got that right. Really well done. So Klebsiella pneumonia is typically seen in alcoholics, and they get red currant jelly sputum. So that's a high yield association. Where else do we see red currant jelly in medical school exams? So you see it here for pneumonia, Klebsiella pneumonia. What is the other disease that it's associated with? Yes, good. Interception in young children or babies. They get red currant jelly stools, and that's interception. Red currant jelly sputum is Klebsiella pneumonia, and it's associated with elderly and alcoholic patients. It's a bacteria which is aspirated into the respiratory tract, and it's typically associated with red currant jelly sputum. Staph aureus, sorry, that's an incorrect explanation. That wouldn't give you red currant jelly sputum. Coxiella causes Q fever, and it's associated with farmers and vets because Coxiella is found in cattle. Mycoplasma pneumonia is an atypical pneumonia seen in young adults, and Chlamydia psittaci pneumonia is associated with exposure to birds like parrots. So we classify pneumonia into community-acquired, hospital-acquired, and aspiration pneumonia. So if we start off with community-acquired pneumonia, we can further divide that into typical and atypical community-acquired pneumonia. So when we say community-acquired, it's literally what it says on the tin. It's, you go and you acquire the infection in the community, i.e. away from the hospital. Typical organisms are strep pneumoniae, which is the most common cause of pneumonia, Haemophilus influenzae, which is associated with COPD. So patients with COPD in the community are at risk of developing pneumonia secondary to Haemophilus influenzae. And Staphylococcus aureus, typically this develops after a viral infection like the flu. Patients then get secondary bacterial infections with Staph aureus, and it can be quite nasty, leading to abscesses and empyema. Now we have community-acquired pneumonia, which is atypical. So what do we mean by atypical? These patients present atypically, i.e. they don't often come with a productive cough and a fever. They may come with headaches, muscle aches, a dry cough, a bit of shortness of breath. So it's not the typical pneumonia presentation. The organisms are often difficult to grow and to gram stain. And remember in that diagram I showed you with the alveoli filling up with fluid and you getting that inflammation, well, in these atypical pneumonias, you tend to get interstitial inflammation. That's the interstitium gets inflamed, i.e., more of the connective tissue and the bits between the alveoli rather than the alveoli themselves. Although the alveoli will still be involved, of course, but you tend to get more of the interstitium being involved. Organisms include Mycoplasma pneumoniae, and we see these in young adults. Patients who get Mycoplasma infections, high yield exam associations, they can develop autoimmune hemolytic anemias and a rash known as erythema multiforme. I mean, I've never seen a patient with mycoplasma developing these, but the exams like to test these key associations, so make sure you know them. Legionella pneumonia, is caused by exposure to a contaminated water source. So in your exams, what they'll do is they'll say, you know, a 40-year-old businessman recently came back from a conference in Spain and has now developed a cough. And they'll give some blood results and show that he's got a lymphopenia and hyponatremia. The whole reason for saying that he's been to a conference is because conferences are air conditioned, and air conditioning is a classic source in exams for Legionella, okay? Because obviously air conditioning units use water, and then Legionella can grow in that water. And actually that sort of presentation, you know, it is possible. I've seen similar things where patients have, or a group of people have all been on an air conditioned bus and subsequently developed Legionella pneumonia from that because the air conditioning water was contaminated. So you do see things like that in clinical practice. Chlamydia psittaci is associated with birds. So if you know, patients who keep parrots, for example, are at increased risk of this. And Coxiella burnetii causes something called Q fever. And it's typically seen in farmers and vets because Coxiella is found on cattle. And these all cause atypical pneumonias. So not that classical presentation of productive cough, yellow sputum, high fevers. You don't tend to get as much of that, more of a dry cough, lower fevers, headache, muscle ache, general under the weather type presentation. Hospital-acquired pneumonia is exactly what it says on the tin. It's pneumonia acquired in hospital after 48 hours of admission. It can be caused by a whole host of bacteria, Pseudomonas, E. coli. This is methicillin-sensitive Staphylococcus aureus, or alternatively methicillin-resistant Staphylococcus aureus. These are a bit more tricky to treat and may require broad-spectrum antibiotics. Something important to note is there is a subtype of hospital-acquired pneumonia called ventilator-associated pneumonia for patients on ITU who are intubated. They are susceptible to ventilator-associated pneumonias, which can be even more tricky to treat. Okay, and this is relevant because people who have COVID, for example, go on ventilators for long periods of time. They can then develop secondary bacterial infections known as ventilator-associated pneumonias, and that makes it even more difficult to treat them. And finally, we have aspiration pneumonia. So that's where you inhale oropharyngeal contents. And again, this can be caused by a whole host of bacteria, really. Anything that you swallow, you know, any of the bacteria that's in your upper oropharynx or within your sort of gut, that you swallow that into your respiratory tract, that can cause an aspiration pneumonia. So Klebsiella, strep pneumoniae, Staph aureus, Haemophilus influenzae, or anaerobic bacteria like Bacteroides. These, you know, you find these in your gut. So if you aspirate and these bacteria enter your lungs, you can then develop what's called an aspiration pneumonia. And these can be tricky to treat. They may require broad spectrum antibiotics. And, you know, you need to make sure you cover anaerobic bacteria with your antibiotics. So when you're choosing your antibiotics, make sure that you're covering for a broad range of bacteria as well as anaerobic bacteria. And we'll come on to which antibiotics you choose. Sorry, ignore this line about VAP. That's, that was carried over from the last slide. Where in the lungs is aspiration pneumonia most likely to occur? It's a high yield question that you'll see in your exam. So where in the lungs is aspiration pneumonia most likely to occur and why? So it's the right lower lobe, very good. I don't have a picture here, but if you imagine that you have the trachea coming down, I can probably do a quick diagram. You have the trachea. If we say this is right and this is left, so you have the left main bronchus comes off at a nice sharp angle, whereas the right main bronchus comes off at more of a shallower angle. So anything that you aspirate is most likely to enter the right and go to the lower lobe, okay? So it's just to do with the angling of the bronchus. And that's why you most typically see these in the right lower lobe. But of course, it doesn't mean it can happen anywhere in the lungs, but just most commonly right lower lobe. Clinical features of pneumonia. So we're most typically thinking about productive cough, shortness of breath, pleuritic chest pain. You can get some hemoptysis, fevers, then other symptoms to think about: headaches, loss of appetite. If they're very unwell and septic, they'll be tachycardic and hypotensive. So just bear in mind some of those additional features. How are we going to investigate this? Starting off at the bedside, sputum culture is the key. You want to get the patient's sputum, send it to the lab for microscopy, culture, and sensitivity. So microscopy means gram staining. Culture means you grow the bacteria and you can see exactly what bacteria it is. Because even though if we gram stain it, it's gram positive, there's lots of different types of gram positive bacteria. So we want to know exactly what type of bacteria it is. And we do that with culture. And sensitivities tell you which antibiotics the bacteria is susceptible to, or resistant to, for that matter. Bloods, their white cells will be raised, their CRP will be raised. If the infection is severe, they'll develop acute kidney injury, which will raise their creatinine and urea. And that's why urea is a measure in the Curb score. If they are hypoxic, you can do an ABG to check their PO2 and see the extent of their respiratory failure. And of course, the staple of pneumonia is to do it, if they come to hospital, is to do a chest x-ray. And you may see consolidation, particularly for typical pneumonias. In atypical pneumonias, they may not actually develop any consolidation because remember, a lot of that inflammation is not actually happening in the alveoli, but is happening in the interstitium. So with atypical pneumonias, they may or may not get consolidation. Investigations to consider: urine antigens. You can test the urine to see if they've got strep pneumoniae, which is the same thing as pneumococcus. And you can also test the urine for Legionella, if you're worried about Legionella pneumonia. And if you're worried about mycoplasma, you can send off the blood for serology and see if they have the antibodies against mycoplasma. So this is a chest x-ray. And this opacity here, this is consolidation, okay, from an infection. So this patient, if we assume, they had a productive cough and shortness of breath, you can see they've got this area in their right lower zone. And that represents consolidation from the infection. It's fluid filling the alveoli, and that then gives us this appearance. These lines here, those aren't normal either. That's called atelectasis. Okay, so that's a small area of collapsed lung, giving this line-like appearance, and that's called atelectasis. The left side is clear. So Curb score, very important in determining management. Curb 65, confusion, urea, respiratory rate, blood pressure, 65. You score 1 point for each of these. So confusion is defined as an AMTS as less than or equal to 8, or if you just simply can see that they're disorientated, then the patient is confused. If their urea is raised above 7, if their respiratory rate is 30 or more, if their blood pressure, the systolic is less than 90, or the diastolic is less than 60, or if their age is 65 or over, they score a point for each of those. So the maximum score you can get is 5. If their Curb score is 2, you need to consider admission. And if their Curb score is above 2, you need to consider ICU. So in practice, I know in the textbooks and things, this is almost said as fact. Like if their Curb score is 2, then they definitely be admitted. If their Curb score is 3, then you definitely send them to ICU. But you need to take the whole clinical picture into consideration. So if their Curb score is 2, you may consider admitting them. And if it's above 2, you may consider sending them to intensive care. But it's a good measure of severity of the pneumonia. So how do we manage these patients? Split up into the 3 classifications: community acquired, hospital acquired, and aspiration. So remember, community acquired, going back to our basic principles we discussed at the beginning. Number 1, where is the infection? It's in the lungs. So we need an antibiotic which can target the bacteria in the lungs properly. What organisms are we talking about? We're talking about strep pneumoniae. We're talking about atypical organisms like mycoplasma. Okay, and then beyond that, we need to think about the severity. And that's why we use the curb score. And then the 4th point was thinking about contraindications. So is the patient allergic to penicillin, for example? In low severity community acquired pneumonia, we can use this is according to NICE guidelines, one of amoxicillin, doxycycline, or clarithromycin. All of these will cover the appropriate organisms. When I'm talking about management here, by the way, this is empirical treatment. So this is before you have the sputum results telling you what bacteria the patient is growing. So before you have that information, you can treat them with these antibiotics here. So if it's low severity, amoxicillin, doxycycline, or clarithromycin. If it's moderate severity, still amoxicillin, but you may want to use that with clarithromycin or erythromycin. So these are your macrolides. The reason you combine antibiotics here is because, or you may want to combine antibiotics here, is because the macrolides give you really good cover against atypicals. Okay, macrolides give you really good atypical cover, and penicillin gives you really good gram-positive cover, and it gives you some atypical cover as well. So putting the 2 together, you're going to properly cover the range of bacteria which cause pneumonia. And if it's high severity, then you're thinking of IV antibiotics. You want a strong penicillin like coamoxiclav. And again, you can add in a macrolide to make sure you have really good atypical cover. So that's why knowing the bacteria which cause the infection is really important, and knowing which antibiotics target those bacteria is really important. In hospital-acquired pneumonia, you just need to think about how severe it is, and there's no score we use. We don't use the curb score for hospital-acquired pneumonia. This is just a clinical decision. If it's low severity, you can get away with giving them oral coamoxiclav. Coamoxiclav is fairly broad spectrum, by the way. And if it's high severity, then you need to use something, properly broad spectrum, like IV tazocin. So going back to that picture that I showed you at the beginning, tazocin sort of spans a large part of the diagram and covers a lot of bacteria. Because remember, hospital-acquired pneumonia, the reason you need something broad spectrum is because it can be caused by a number of bacteria. It's not just, you're not just thinking strep pneumonia, you're thinking about things like Pseudomonas, etc. If the patient has confirmed MRSA, then you can add in vancomycin. Remember, vancomycin covers MRSA. In aspiration pneumonia, again, the treatment is variable. That's because of the wide range of bacteria that can cause aspiration pneumonia. We need to make sure that we cover gram-positive, gram-negative, and anaerobic bacteria. So amoxicillin is pretty good at covering the gram-positives, and I'll give you a bit of gram-negative cover. Metronidazole is really good at covering anaerobes. So that's why you can combine these 2 in aspiration pneumonia. Just going back to, remember, aspiration pneumonia can be caused by a number of bacteria from the gut, and that can include your gram-negatives, that includes your anaerobic bacteria. And that's why it's really important that we have broad coverage in aspiration pneumonia. Good, that's pneumonia in a nutshell. So now we're going to move on to our urinary tract infections. Feel free to ask any questions you have as we go along, and I'll either answer them now or I'll get to them at the end. But hopefully that all kind of made sense. Okay, next case. 55-year-old lady presents with burning pain when passing urine. She had to get up 4 times at night to go to the bathroom, and she's previously had urinary tract infections. Her OBS in this case are actually okay. Her heart rate's 90, the blood pressure's fine. The rest rate's a bit high, saturations are fine, and the temperature's fine as well. So in UTI, which of the following is the most likely causative organism? Gram-negative rot. Good. What is the most likely organism? What bacteria are we talking about? Very good, E. coli. So the most common cause of urine infections, whether that be UTI or upper urinary tract infections, i.e. pyelonephritis, is E. coli. Gram-positive rods don't typically cause UTIs, neither do gram-negative cocci. You can get gram-positive cocci like Enterococcus and Staphylococcus saprophyticus, which cause urinary tract infections. Okay, so how do we define the infections here that we're talking about? So we have UTIs, which typically mean bladder infections, i.e. cystitis. So when we say the patient has a UTI, we mean they've got bladder infection. When we're talking about upper urinary tract infections, i.e. those infections affecting the kidneys, that's called pyelonephritis. Okay, so UTI refers to a bladder infection, and upper tract infections of the kidneys called pyelonephritis. UTI can further be divided into complicated and simple. Complicated UTIs are those where you have an increased risk of persistent infection or complications. So an example of a complicated UTI would be in someone who has a catheter, because of course, if you have a catheter, bacteria can colonize the catheter and they'll keep getting infections over and over again, potentially. So complicated UTIs. Important to bear in mind because you treat them slightly differently. You tend to treat them for a bit longer. Epidemiology, it's very common in women. NICE say it happens in up to 50% of females, and almost a third will have recurrence. Pyelonephritis is rarer. Age, so UTIs are more common in the elderly. Pyelonephritis tends to happen in a bit of a younger population. More common in females because they have shorter urethras. So if you look here, the path from the urethra to the bladder is very short. So the bacteria can infiltrate the bladder very quickly. Whereas in males, that path is a lot longer. So the path that the bacteria needs to take is longer, and therefore infection is less likely. Post-menopause is a risk factor because estrogen is normally protective, and in menopause, your estrogen levels drop. Sexual intercourse is a risk factor. Again, that's a way of introducing bacteria into the urinary tract. Of course, catheterization, anatomical abnormalities, and as with any infection, immunosuppression is a risk factor. So how does it occur? UTIs, it's simply bacteria ascending through the urethra to the bladder. That's the most common cause. Hematogenous spread, so bacteria in the blood then infiltrating the bladder, is rare. And direct introduction, i.e. through a catheter, again, that's less common. The most common cause is bacteria essentially climbing up the urethra into the bladder. Pyelonephritis most commonly occurs as basically you get bacteria ascending from the bladder into the kidneys. So it's essentially the next step. You have bacteria ascending through the urethra to the bladder, and then from that, the bacteria can potentially ascend up into the bladder, causing a kidney infection. Other causes include obstruction, so a renal stone. So going back to this diagram, imagine if you have a stone blocking the whole system. So if you have a stone somewhere here, that's going to block drainage of the kidney, and all of that urine is going to start pooling in the actual renal pelvis, and that's going to form a source of infection, and then patients will get pyelonephritis. Again, hematogenous and direct introduction is less common, but it is possible. Someone's asked, can a UTI progress to pyelonephritis? Yes, definitely. So UTIs can certainly progress to kidney infections. Organisms, E. coli is by far the most common, and that's because E. coli has these little proteins on its outside that can attach to the epithelium lining the urinary tract and anchor itself into that epithelium, and then that will of course cause infection. Klebsiella, Enterobacter. This is a common exam one, important for you to know. Staphylococcus saprophyticus is a cause of what's known as honeymoon cystitis. It's typically seen in the younger female population, and it's associated with intercourse. So Staphylococcus saprophyticus is one that you might see in your exams. Proteus is associated with renal stones, catheterizations, or anatomical abnormalities, and Pseudomonas and Candida are associated with catheterization. So that's essentially the bacteria which cause UTIs and pyelonephritis. The ones down here, Proteus, Pseudomonas, and Candida are typically seen in complicated infections. Okay, so these three down here are associated with complicated, complex UTIs. Clinical features of UTI: dysuria, so pain on passing urine. Frequency, that means going to pass urine several times per day. Urgency means that you always have the need to go, even if your bladder's not actually full, you always feel like the need to rush to the toilet. And that's because your bladder wall is essentially, it's irritated by the infection. Changes in urine color, it might be smelly, it might be cloudy, and patients may have suprapubic tenderness. Pyelonephritis, you can get all of these UTI symptoms, because remember, pyelonephritis commonly occurs as a subsequent progression of a UTI. So you get all of those UTI symptoms, plus patients are more systemically unwell. They'll commonly feel nauseous and vomit. They'll have flank tenderness over the affected kidney. They are typically pyrexial and maybe rigoring. You don't typically get fevers in UTIs, but you do in pyelonephritis, okay? You can, of course, still get feverish in UTIs, but it's more typically seen in pyelonephritis. How do we investigate it? Well, if it's just a simple UTI, you might just do a urine dip and not continue any further. But regardless, at the bedside, you want to do a urine dip, looking for things like nitrites, leukocytes, and red cells. And again, you want to send, like we did before, we sent the sputum for culture, we want to send the urine for culture. Gram staining, that's microscopy. Culture is growing the bacteria and seeing which specific bacteria is the cause. And sensitivity is looking at the antibiotic sensitivities and which ones are resistant and which ones are sensitive. According to NICE, if the urine dip is positive for nitrites or leukocytes and red blood cells, a UTI is likely. If it's negative for nitrites and positive for leukocytes, a UTI is still, it's still possible. They say it's equally likely to other diagnoses. Bloods, we don't always need to do bloods in a UTI. And in fact, the majority of UTIs presenting to primary care will not have bloods done. We will need to do bloods if the urinary tract infection is severe, or typically in pyelonephritis, we do tend to do bloods, particularly in the emergency department, because they can, pyelonephritis can be quite a severe, nasty infection. Again, we're looking at raised white cells and inflammatory markers. The patient may have a AKI because, of course, the kidneys may be directly affected by the infection. And if the patient is really unwell and you're worried they're septic, do a blood culture. After you've done all of that, you may want to consider a renal ultrasound, because you can look at the anatomy of the kidneys and the bladder. You want to make sure there's no stones. You want to make sure there's no structural abnormality which could be predisposing the patient to the infection. Okay. We should be finishing up in the next sort of 5 or so minutes, so please do bear with me. I apologize for going over a little bit. What is the typical duration of treatment for a UTI in a non-pregnant female? So a simple UTI in a non-pregnant female. Good, so you guys are doing really well on these questions today. 3 days. So typically, I didn't say this, but for respiratory tract infections, we go for 5 days. For UTIs, we go for 3 days. Sometimes we do go for 7 days, depending on if there's any additional features, like if the patient's pregnant, or if it's a male, then we go for a longer course. But otherwise, simple UTIs in female, 3 days. What antibiotics do we use? Trimethoprim or nitrofurantoin. Those are the 2 commonest first-line agents, and we treat for 3 days. This is in a female. If the patient is catheterized, then you treat them for longer. That's because, you know, of course, if they're catheterized, you want to make sure that you eradicate the catheterization. We see you have instrumentation of the bladder. There's potential for those bacteria to colonize and sit in the bladder for a lot longer. So you want a slightly longer course. And if they do have a catheter in, you want to consider changing that catheter, because if that's the source of infection, you want to change that catheter for a new one. Just as a really important point, some patients just have bacteria in their urine that doesn't cause them any infection or problem or symptoms. We don't treat that. So if you went and did a urine culture on everyone in the population, a proportion of those people will have bacteria in their urine that's not causing them any problem, and we do not treat that. That's known as asymptomatic bacteria. However, in pregnant women, you do treat that. So in pregnant women, you treat UTIs and you treat asymptomatic bacteria with antibiotics. And interestingly, all pregnant women must have a urine culture in their first antenatal visit. The reason you treat the asymptomatic bacteria in pregnant women is because there's a risk that the bacteria in the urine can ascend into the kidneys and cause pyelonephritis. And obviously, if the woman is pregnant, that's not good. We treat pregnant women for a bit longer, 7 days, and we use nitrofurantoin. Why can we not use trimethoprim in a pregnant female? So good. Why is it teratogenic though? What does trimethoprim do? Remember, going back to our mechanism of actions, it's a folate antagonist, very good, blocks DNA synthesis. Dihydrofolate reductase inhibitor, which prevents folate production. If you can't make folate, you can't make DNA. If the baby can't make DNA, then of course it's going to be teratogenic. In males, again, it's the same story, trimethoprim with nitrofurantoin, and you treat them for a bit longer, 7 days. I'm not actually sure why it's longer. I assume it's because the urethra is longer and there's probably, you know, more sort of bacteria colonizing the urinary tract. So you give them a bit of a longer course to make sure you've properly cleared those bacteria. Remember, this is empirical treatment. So this is before the antibiotic sensitivities are back. Once you have the antibiotic sensitivities back, then you may need to change your antibiotic or you may not. So as an example, if I've given this female who's come to my clinic trimethoprim, and a day later, the antibiotic sensitivity comes back and says, well, actually the urine is resistant to trimethoprim, then I'll switch her to nitrofurantoin, for example. So always important to check the sensitivities, but of course it takes time for those sensitivities to come back from the lab. Pyelonephritis. So pyelonephritis is a bit more of a severe infection, so we need to hit them with, stronger antibiotics with a longer duration. This is according to NICE guidance. There's a whole host of antibiotics you can choose. Cephalosporins like cefalexin, coamoxiclav, fluoroquinolones like ciprofloxacin, trimethoprim. You can use, any one of those. If they're pregnant, use cefalexin. And if it's severe, you can use, again, any one of these. What I've seen in my clinical practice is IV coamoxiclav plus or minus gentamicin, depending on how severe the infection is. Okay, so if it's a severe pyelonephritis, you will combine both coamoxiclav and gentamicin. If it's not too bad, then you can get away with perhaps just IV coamoxiclav. Again, check the antibiotic sensitivities. All right, so let's just wrap up there. Please do check out our online textbook and question bank. And remember, you've got my discount code of XRAY 2021. There's a recap there for you to go over in your own time, and the recordings will be uploaded within the next couple of days. Please do fill out the feedback form. That's really helpful for all of us. And if you have any questions, I'll stick around for a couple of minutes